Welcome to this clinical guide on C-reactive protein, or CRP, for UK practice. This video will cover the mechanism, interpretation, and relevant NICE guidance for CRP. CRP is an acute phase reactant. Tissue injury or inflammation stimulates the release of IL-6, targeting the liver. This results in the rapid synthesis of C-reactive protein, which increases in concentration in response to acute processes. There are two main CRP assays. Standard CRP focuses on acute diagnosis, measuring higher concentrations to diagnose and monitor acute inflammatory conditions. High-sensitivity CRP, or hs-CRP, measures very low concentrations and assesses chronic low-grade systemic inflammation for cardiovascular risk. Understanding the reference ranges is key. Below 5 milligrams per liter is normal. A mild increase is below 10 milligrams per liter. Moderate elevation, 10 to 50 milligrams per liter, suggests significant infection. A marked elevation above 50 milligrams per liter strongly suggests significant infection, with bacterial infections often exceeding this threshold. CRP has three main clinical utilities in primary care: differentiation between viral and bacterial etiology, tracking disease activity in non-infectious inflammatory diseases, and as a red flag for persistent, unexplained elevation which warrants investigation for potential malignancy. NICE Guidance NG 191 recommends using CRP for antibiotic stewardship in community-acquired pneumonia. If an adult has suspected pneumonia and moderate severity illness, consider a CRP test to guide antibiotic prescribing in equivocal cases. NICE Guidance NG 51 highlights CRP's role in sepsis and acute infection. A rapidly rising or very high level is strongly indicative of severe systemic infection. This requires urgent management and referral. hs-CRP is used for cardiovascular risk assessment. It detects chronic low-grade inflammation, typically below 10 milligrams per liter, and is used to reclassify risk in intermediate risk patients. This is distinct from the acute use of standard CRP. Limitations of CRP testing include non-specificity. It indicates inflammation but not the site or cause, requiring clinical context for interpretation. Also, drugs like NSAIDs and corticosteroids can artificially suppress CRP levels. The golden rule is focusing on trends and context. The trend is often more informative than a single reading, indicating worsening or response to treatment. Always interpret results alongside the full clinical picture. Treat the patient, not the number. In summary, remember the ranges. Less than 5 is normal, 10 to 50 is moderate, and over 50 is marked, often bacterial. Use standard CRP for acute infection and hs-CRP for cardiovascular risk. Be mindful of critical triggers like sepsis, pneumonia guidance, and investigation for persistent rise suggestive of malignancy.